Hello, my name is Quentin Broussard. I'm an assistant professor at California Health Sciences University, and today we will be discussing miscellaneous electrolyte disorders, including potassium, magnesium, calcium, and phosphorus disorders. And the reason we're discussing these disorders today is because each of these disorders, in addition to sodium disorders, which we discussed in the previous class, can have significant morbidity as well as mortality associated with them. So therefore, it's important as a pharmacist to be able to classify each of these disorders, particularly within their subsets of their corresponding hypo or hyper disorder, as well as to treat each of these disorders appropriately to prevent morbidity and mortality. Our objectives will be to classify each of these miscellaneous electrolyte disorders, including magnesium, potassium, calcium, and phosphorus disorders, to identify etiologies and causes of magnesium, potassium, calcium, and phosphorus disorders, and to compare and contrast treatments of magnesium, potassium, calcium, and phosphorus disorders. So we'll start off with a patient case. GB is a 35-year-old male presenting to the ED with ultramental status and profuse nausea and vomiting secondary to alcohol withdrawal. According to a friend, he's barely eaten in the last week. His labs upon admission include sodium 140, potassium 3.1, chloride 96, bicarbonate 22, BUN 23, serum creatinine 1.0, and glucose of 87. GB has a peripheral IV line. What electrolyte disorder does GB have? Is it hypokalemia, hyponatremia, hyperkalemia, or hypermagnesemia? The second question, what concurrent lab should be obtained to potentially determine the cause of GB's electrolyte disorder in question 1? Is it magnesium, phosphorus, serum osmolality, or urine sodium? And number 3, assuming the lab taken in question 2 is normal, how should GB's underlying electrolyte disorder be treated? With calcium gluconate 1 gram IV times 1 over 10 minutes, normal saline 1,000 mils times 1 over 1 hour, potassium chloride 10 milligrams IV times 4 over 4 hours, or insulin 5 units sub-Q and dextrose 25 grams IV times 1. After we discuss each of the different electrolyte disorders today, you should be able to answer each of these questions confidently. So we're going to break up each of these disorders into first their electrolyte and give a quick background about the electrolyte. And then we're going to actually break down the disorders with each electrolyte, including their hypo and hyper corresponding disorders. So the first electrolyte we're going to talk about is magnesium specifically. A little background on magnesium. It is the second most abundant intracellular cation, and it's present in total, its presence makes up 1% of in extracellular fluid, with 99% of it being in the cell itself. Normal serum concentration of magnesium typically ranges between 1.7 to 2.3, though some sources may say anywhere between 1.5 and 2.5. Just be aware that different hospitals as well as different resources will say different things. For our purposes, just to keep things a little more on the concrete side, we're going to say 1.7 to 2.3. This may be a little bit restrictive, but this is one of the ranges that is used in some practice settings. Magnesium is found primarily in bone, muscle, and soft tissue, and serves as a cofactor for many different enzymes, biochemical reactions, including reactions involving ATP, particularly those involving the sodium-potassium ATPase pump, which magnesium serves as a cofactor in causing to function. Magnesium is absorbed in the small intestine, and it is mostly handled by the kidney in terms of its homeostasis. So the kidney basically regulates its elimination. However, GI function obviously regulates its absorption, as well as other things may regulate its serum levels, such as parathyroid hormone, plasma and magnesium concentrations itself, certain clinical conditions, alcohol, particularly in patients who have an alcohol history or an alcohol abuse disorder, and medications like loop diuretics and amphotericin B2, which some medications may actually promote hypomagnesemia for the most part. Going into hypomagnesemia specifically, hypomagnesemia is defined as a serum magnesium concentration of less than 1.7 per our definitions here. And severe hypomagnesemia, we're going to consider less than 1. So just be aware of what the normal range is, so the 1.7 to 2.3. I wouldn't be as concerned about the severe level for testing purposes, but be aware that if it's this low, it's a pretty severe manifestation. In regards to different causes of hypomagnesemia specifically, excessive GI and or renal losses may play a role. So like we said, magnesium is absorbed by the GI tract and can be eliminated and regulated by the kidney. So any kind of losses there would result in hypomagnesemia. Other miscellaneous causes include surgery, trauma, infection, or sepsis. Sepsis is essentially a worsening of infection to the point where it actually potentially can affect your organ systems and cause organ failure. Burns may be a reason for hypomagnesemia. Transfusion of blood products preserved with citrate. And the reason why this is a concern is that magnesium actually will chelate with citrate and bind to citrate. And as a result, that magnesium is no longer measurable in the serum because it is bound to the citrate. Starvation and malnutrition and alcoholism are probably some of the biggest causes of hypomagnesemia. Essentially, if you don't take in magnesium, then you won't have an adequate serum magnesium level. And as pharmacists, it's important to know about medications that may promote hypomagnesemia. Some of these medications include loop diuretics, including furosemide, bumetanide, or torsemide, which are used to take fluid off of patients. Aminoglycoside antibiotics that are used to treat gram-negative infections such as gentamicin and tobramycin. Amphotericin B, which is used as an antifungal agent. Cyclosporin, which is used as a transplant rejection agent. And digoxin, which is used particularly in cardiac disorders, specifically atrial fibrillation, but it also may have some utility in heart failure as well. So what are the signs and symptoms of hypomagnesemia? The most common things that you might see with hypomagnesemia specifically are a concomitant refractory hypokalemia and hypocalcemia. And this can occur with any level of hypomagnesemia. So what essentially this means is if your magnesium is low, you have a high chance of having concurrently a low potassium and or a low calcium level. And the hypokalemia part is likely due to impaired activity of that sodium-potassium ATP ACE pump here, or increased renal losses. So essentially, without enough magnesium, essentially these processes don't work properly, and as a result, hypokalemia can occur. So whenever we talk about hypokalemia in a bit, it's important to always treat the underlying cause of your electrolyte disorder. So in this case, this hypokalemia case, you would want to treat the hypomagnesemia first, but you may also have to treat the hypokalemia at the same time. In terms of the things that you might see with severe hypomagnesemia or serum magnesium less than 1, you may see ECG or EKG changes, electrocardiogram changes, particularly arrhythmias, and this can include torsades, or twisting of points, where this rhythm might be potentially fatal. And actually the treatment of choice for torsade to point is to give IV magnesium. You may also see seizures, coma, and death result from hypomagnesemia. In regards to hypomagnesemia treatment, oral magnesium supplements may be given, however, they're pretty problematic. So they have a slow onset of action, and they have a high incidence of GI intolerance, such as nausea and vomiting. So many people will probably not want to take these agents, though one agent that is commonly prescribed for the purposes of oral magnesium replacement is magnesium oxide, just an FYI. The IV route of administration is preferred for replacement, and the most common type of IV replacement is magnesium sulfate, as you see here on the right. Just something to know about for magnesium, 1 gram of magnesium sulfate is equal to 8 milliequivalents of magnesium sulfate. And that is the maximum amount that's the maximum rate of infusion of mag sulfate is 8 milliequivalents, or 1 gram per hour. Because a lot of these electrolytes are eliminated by the kidney, if your kidney is not functional, your kidney will actually cause overaccumulation of these electrolytes. So as a result, if you have a kidney dysfunction, such as acute kidney injury or end-stage renal disease, with or without dialysis, you may want to reduce the dose by 50% for patients with renal dysfunction so they don't overaccumulate and then convert into a hypermagnesemia disorder. You want to ideally monitor serum magnesium levels daily during repletion, though you may need additional magnesium supplementation over a few days, as magnesium distributes very slowly in the body. So you may actually need repletion for 3 to 5 days after your initial treatment of magnesium. It's important to note that the serum magnesium levels don't necessarily always reflect the body stores of magnesium, and that can be said for most of the electrolytes that we talk about today. So in regards to magnesium itself, here you just see an empiric drug chart of the different treatments for magnesium and how much magnesium to give. Again, look at this concentration here. Obviously, with mild to moderate magnesium concentrations, you don't give as much magnesium replacement dose. However, with severe, you have a much higher ceiling of how much magnesium you can give. Again, remember that the max rate is 8 milliequivalents of mag per hour. That's an important threshold not to exceed. For hypermagnesemia is essentially defined as mild, moderate, or severe. So essentially the big thing that I want you to get from this is that mild hypermagnesemia in general is considered anything 2.4 and above, depending on which reference, again, that you look at, with severe hypermagnesemia being over 12.5. So there's actually a pretty wide range of hypermagnesemia disorders that you see here. Some common causes of hypermagnesemia, probably the most common cause is renal insufficiency. So again, that AKI, if you have acute kidney injury or end-stage renal disease, requiring or not requiring dialysis. So you see here on the right side, this left side is essentially a healthy kidney. This right side is a polycystic kidney here. That's not necessarily significant for all renal dysfunction. It's just trying to give you an idea that for patients who have high mag levels, this can be one of the potential causes is a bad kidney, which could lead to potential end-stage renal disease. In regards to signs and symptoms of hypermagnesemia, mild hypermagnesemia is actually usually asymptomatic. Hypermagnesemia doesn't tend to happen a lot in practice. just FYI. For those who have moderate hypermagnesemia, that's whenever the symptoms really start. And you might see nausea and vomiting, loss of deep tendon reflexes, hypotension, bradycardia, and then again the EKG or ECG changes. And with hypermagnesemia, it's more increased PR and or QRS intervals. Severe hypermagnesemia is essentially a medical emergency that's above 12.5 milligrams per deciliter. And that can result in respiratory paralysis, refractory hypotension, AV block, and cardiac arrest. In terms of hypermagnesemia treatment, the most important thing is always treat the underlying cause. So if you're giving patients exogenous magnesium, PO or IV sources, you need to discontinue that immediately because that's making the hypermagnesemia worse. For patients who have asymptomatic or moderate hypermagnesemia, you can give them loop diuretics. You can restrict their magnesium intake. And in some cases, you might actually need renal replacement therapy or dialysis or hemodialysis, which essentially will take the blood out of the patient, filter it, remove some of the smaller ions and different chemical structures that are in the body, particularly electrolytes. So electrolytes get taken off pretty easy by dialysis. And then that blood gets filtered back. In the event your patient has cardiovascular or neuromuscular effects from hypermagnesemia, you may want to give them IV calcium to reverse these. You can give calcium chloride 500 milligrams to 1,000 milligrams IV over 5 to 10 minutes via a central line and repeat it until the symptoms resolve. If they don't have a central line, calcium gluconate will work just fine, 1 to 3 grams IV over 3 to 10 minutes. Again, this does not happen very often, but it's still important to be aware about if you do have an emergent case. So now we're going to move on to potassium. Potassium is the second most abundant cation in the body, and 98% of it is intracellular. Our normal serum concentration is between 3.5 to 5.0 milliequivalents per liter, though in some references you may see up to 5.5. It serves roles in cellular metabolism, glycogen and protein synthesis, and regulation of electrical action potentials, especially in the heart, particularly in the repolarization phase. So essentially, remember, with action potentials, you may have a sodium or a calcium influx, and then to repolarize, you'll have a potassium efflux, essentially out of the cell. And that is essentially relating to the fact that 98% of potassium is intracellular. Now, potassium is regulated by those sodium-potassium ATPase pumps, and that shifts potassium back into the cells after that repolarization occurs. However, there are many factors that affect this pump, such as insulin, glucagon, catecholamines, aldosterone, patient's acid-base status, plasma osmolality, and intracellular potassium levels. Again, 80% of potassium, as well as a lot of the other electrolytes in the body, are excreted through the kidneys. So if you have patients who have end-stage renal disease and are not able to pee out potassium, you may have overaccumulation. So keep that in mind whenever you are replacing a patient, particularly if they have hypokalemia, which is our next topic, hypokalemia. So our definition for hypokalemia is a serum potassium concentration of less than 3.5, and it's considered severe if the level is less than 2.5 or if they are symptomatic as a result of the hypokalemia. In regards to causes, some hypokalemia causes can be categorized into different categories. So there are things that may increase potassium losses, such as potassium wasting diuretics, such as leuprothiazide diuretics, so furosemide, bumetanide, torsemide, or hydrochlorothiazide. Sodium polystyrene sulfonate, or SPS or K-exalate, which we'll talk about as a treatment for hyperkalemia. Mineral corticoids, particularly fludrocortisone. Amphotericin B, if you remember amphotericin B, as well as aminoglycosides we talked about causing hypomagnesemia. Well, they also cause hypokalemia as well. Renal replacement therapy or dialysis can obviously take off potassium. And magnesium depletion, because magnesium serves as a cofactor for that sodium-potassium ATPase pump and may actually cause excessive renal loss of potassium via another mechanism. So that's why it's always important to obtain a serum magnesium level whenever you're trying to assess hypokalemia. In regards to things that may shift potassium inside the cells, those include things such as beta agonists like albuterol, insulin, which both beta agonists and insulin are used for treatment of hyperkalemia, and you may also see theophylline or caffeine cause hypokalemia as well, particularly if used chronically. Decreased ingestion or administration of potassium is also a potential problem, and metabolic alkalosis is potentially something that may cause hypokalemia. And we'll talk more about metabolic alkalosis specifically whenever we talk acid-base disorders next week. In regards to hypokalemia signs and symptoms, hypokalemia may result in impaired muscle contraction, nausea and vomiting, weakness, respiratory compromise, constipation, paralysis, rhabdomyolysis, or essentially muscle breakdown. Also, EKG or ECG changes, and which can result in arrhythmias, cardiac arrest, and then sudden death. It's important to note that a lot of these different symptoms will occur mostly with potassium levels less than 3. Typically, mild hypokalemia in practice is asymptomatic. So anywhere within that 3 to 3.4 range, typically you won't see any symptoms of it, but it's still something that you would want to replace because it may become lower later. So in regards to hypokalemia treatment, kind of like what we mentioned before, it's important to check a magnesium level because hypomagnesemia may result in concurrent hypokalemia, like we talked about with magnesium. So always check a magnesium level before fully assessing your K, because you might actually have to give magnesium in addition to K to increase your potassium level. In regards to supplementation, you can administer either PO or IV potassium supplementation to treat a hypokalemia. So IV potassium is typically reserved for patients who have severe or symptomatic hypokalemia or when the GI tract cannot be used. So if a patient has like nausea and vomiting or any kind of intolerance to oral intake or is in PO status for some reason, those patients are the ones that should get IV potassium versus PO. In terms of the common salt form that's most common in practice, potassium chloride is the one that's most common, though you may see other things such as potassium bicarbonate, potassium acetate, or even potassium phosphate, which we'll talk about with the phos disorders. Another thing that you can potentially do, which is not a potassium supplement per se, is you may give a potassium-sparing diuretic, such as spironolactone, triamterene, or miloride. These diuretics, via their mechanism as potassium-sparing, will actually cause reabsorption of potassium in the kidney. And as a result may boost potassium levels on their own, though they are not necessarily preferred as first line for hypokalemia treatment. That is reserved more so for PO or IV potassium supplementation. An important rule to note is if a patient has normal renal function, you can replace with 10 milliequivalents per every 0.1 milliequivalent per liter increase in your serum potassium concentration that you desire. So, for example, if you desire a 0.4 increase in your serum potassium level and you have normal renal function, you should administer about 40 milliequivalents of potassium. This rule seems to work out pretty well in most patients who have normal renal function, though it may be off just a little bit slightly. Now, if they have compromised renal function or AKI or ESRD, that rule pretty much goes out the window. So just be cognizant this rule only works with normal renal function. You may need to reduce the normal IV administration dose by 50% for patients with renal dysfunction. And whenever you administer potassium, it's important for peripheral IV lines that a maximum of 10 milliequivalents per hour is infused, and 20 milliequivalents per hour if you have a central IV line. And if you're doing a central IV line with 20 milliequivalents per hour, you should have cardiac monitoring on your patient so that you can monitor any kind of EKG changes that may occur. Because that can happen as a result of more rapid replacement of potassium. And again, recheck your potassium daily like your other electrolytes. You may also check it a few hours after replacement as well. In regards to potassium replacement, you see here, essentially it's kind of broad in terms of mild to moderate. Ideally, you can use that 10 per every 0.1 milliequivalent per liter rule here, though you probably don't want to exceed too much IV potassium to start out with. That's why I think that this number here is closer to 40 versus for 2.5 going to 100. Ideally, you should be constantly reassessing. You shouldn't overdo it on your potassium whenever you're replacing it. In terms of severe hypokalemia, obviously, they reserve a lot more for that. Now we're going to move on to hyperkalemia. Hyperkalemia is a serum potassium greater than 5 milliequivalents, and this should say per liter. And it's life-threatening whenever you have a level of greater than 6.5. Some hyperkalemia causes include extracellular shifts of potassium. This can occur in metabolic acidosis. If you administer certain medications as well, such as acetylcholine, which is a paralytic used in intubation of patients to get an endotracheal tube down someone's throat so that they can connect it to a mechanical ventilator so they can breathe. Beta blockers such as carvedilol and digoxin, particularly in overdose situations. You may also see extracellular shifts of potassium in muscle injury. So if you have a patient that has some kind of trauma or rhabdo, essentially the breaking apart of cells and the destruction of cells will release that intracellular potassium from the cell and out into the serum. If you have increased potassium ingestion, or if you have impaired potassium elimination. And under this one, renal insufficiency is the primary cause. So if your kidneys are not able to pee it out or eliminate it properly, you're not going to have as much potassium elimination, particularly in those patients who don't pee at all. These are the patients who are probably at the highest risk of hyperkalemia because they can't get rid of anything. In those cases, they may have to resort to dialysis to get the K off. Potassium-sparing diuretics, again, like spironolactone, triamterene, or amiloride. ACE inhibitors and ARBs can also cause it, so lisinopril, losartan, and NSAIDs, such as ibuprofen or naproxen. You may also have something else called pseudo-hyperkalemia. And essentially what we call this in practice is a bad draw. Whenever you're withdrawing blood from someone, what can happen is a hemolysis process or a breakdown of that blood cell. And whenever that blood cell breaks down, remember, within that cell you have potassium, because potassium is highly intracellular. As a result of that rupture, you then get a release of potassium and essentially a fake potassium level. And in these cases where you suspect hemolysis of the blood sample, and you might know about it beforehand or you might not, depending on how good your lab is at telling you regarding this, you may actually need to take another level to reassess your potassium level. So regarding signs and symptoms, hyperkalemia is often asymptomatic until your serum potassium gets above 5.5, and you may see muscle twitching, cramping, weakness, or ascending paralysis. One of the biggest telltale signs that you have a problem with symptoms is if your ECG or EKG changes, particularly presenting with arrhythmias like bradyarrhythmias, VFib and asystole, which VFib and asystole are both medical emergencies which require a crash cart ACLS administration, as well as chest compressions and shocks potentially to resuscitate your patient, depending on which rhythm it is. So hyperkalemia can cause death, essentially. So how do you treat hyperkalemia? You want to ideally discontinue any exogenous potassium sources and other sources that cause hyperkalemia, i.e. medications. Some asymptomatic hyperkalemia options include pretty much almost all of the treatment options for hyperkalemia, and those include dextrose with insulin, because insulin will shift potassium into the cell. Sodium bicarb will also shift potassium into the cell. Albuterol also does the same thing, shifting potassium into the cell, as we'll see on the next slide. Potassium wasting diuretics, such as furosemide, will actually eliminate potassium from the system by essentially leaking it out through the urine. Again, you have to have someone who is able to properly urinate for this to work properly. SPS, or sodium polystyrene sulfonate, or SPS or K-exalate is its brand name, is used as essentially a resin that is used GI-wise to eliminate potassium. And renal replacement therapy or dialysis is always a therapy that's available to eliminate K, as small ions or small elements may be taken off easily via dialysis. Now, if you have symptomatic hyperkalemia, i.e. ECG or EKG changes, arrhythmias, something potentially fatal happening, you can do any of the above therapies, but you need to also do calcium gluconate, and this essentially antagonizes the cardiac conduction abnormalities that are associated with the hyperkalemia, at least for a short period of time. But this does not have an effect on the K, so it's not going to necessarily shift or eliminate your K. It's essentially going to stop or minimize the amount of arrhythmias that you have potentially. Doesn't necessarily mean it's always going to stop it. In some cases, you may have arrhythmias that are refractory to calcium gluconate. So this chart essentially gives you an idea of all the different treatments available for hyperkalemia. I want you to be familiar with the different options that are available. I'm not necessarily concerned about the dose of these agents. The one thing I do want you to focus on in terms of dosing and route is the fact that the insulin here is regular insulin, and it's given with dextrose. So in addition to that, it's given IV. If you remember, the only other indication we've talked about where you give insulin IV is DKA or HHS. So if you see a patient, as well as an order in your verification queue, where the insulin is intravenous, the two things I look for first are DKA, HHS combination, or hyperkalemia. The reason why it's given IV in hyperkalemia is that it's better, it's more erratically absorbed if you are giving it subcutaneously versus IV. And because you're in a medical emergency, you don't want to leave anything to chance. So that's why we give it IV. It's also important to know the different mechanisms of action of each of these different treatments here. Now we're going to move on to calcium. In regards to calcium, calcium is mostly found in bones. About 99% of it is. And its normal serum concentration is between 8.5 to 10.5 milligrams per deciliter. Calcium has many different roles in the body, such as a cofactor for blood coagulation, platelet adhesion, neuromuscular activity, endocrine and exocrine secretory functions, and electrophysiology of heart and smooth muscle. In some cases, it is the electrolyte that actually will be involved in the influx into the cell, causing depolarization of the action potential. Serum levels of calcium are regulated by parathyroid hormone, vitamin D, and calcitonin. In regards to calcium specifically, 50% of calcium found in blood is bound to plasma proteins, primarily albumin. And the problem with this is that though we may in the body, or on a lab show that your calcium level is below range, it actually isn't, because some of that is still bound to that albumin. So in those cases, we want to take a look at our albumin level and correct a calcium for that low albumin, for a low albumin level if necessary. So it's important to know this formula because you may be tested over this later. Your corrected calcium is equal to serum calcium concentration plus 0.8 times the quantity of 4 minus the serum albumin concentration. So essentially this is going to produce an increased value if your albumin is less than 4. So there are many cases where you may have a patient with a calcium of 8.0, but are low albumin, and actually realize that their calcium is normal. So in regards to calcium as well, the ionized calcium is the biologically active form of calcium. In that normal range typically ranges between 1.12 and 1.30 millimoles per liter. This level is not routinely taken on labs, though it may be taken sometimes. And this is just the normal range for that ionized calcium level. This is not a level that you necessarily need to know off the top of your head, but just to be aware that it exists. So now we'll talk about hypocalcemia. Hypocalcemia is defined as a serum calcium concentration of less than 8.5, or an ionized calcium concentration of less than 1.12 millimoles per liter. And it's considered severe if that hypocalcemia is less than 7.5 milligrams per deciliter, or an ionized level of less than 0.9 millimoles per liter. In regards to hypocalcemia causes, remember a lot of calcium is bound to albumin and proteins, so hypoalbuminemia is probably the primary cause of hypocalcemia. But it's important to remember not to give albumin in this case, because sometimes that hypoalbuminemia is a result of decreased production or over increased production or utilization of that albumin in the body. So giving albumin isn't necessarily going to help with this. Another reason why you might see hypoalbuminemia is poor nutritional status. Therefore, you want to ideally correct the reason why they have hypoalbuminemia itself, not necessarily giving them albumin. You have to treat what is causing that hypoalbuminemia itself. And if it's nutrition status, obviously, you need to give them nutrition. Hypomagnesemia may also present concurrently with hypocalcemia. hyperphosphatemia, and essentially calcium and phosphate can be considered kind of friends similar to potassium and magnesium, in that when phos levels tend to go high, calcium levels might go low, and vice versa, though that's not always the case. Infection or sepsis may cause hypocalcemia, pancreatitis, or inflammation of the pancreas. Renal insufficiency may be a problem with hypocalcemia, hypoparathyroidism, as well as administration of blood preserved with citrate. Similar to magnesium, calcium will also chelate with citrate. Both of them are 2+ charged, calcium is 2+ charged, in addition to magnesium. And as a result, they will chelate with citrate and bind, essentially removing that calcium from being in the actual measured in the serum as free level. Some hypocalcemia signs and symptoms. Tetany is probably the hallmark sign of hypocalcemia itself. So essentially, broad muscular, CNS, and cardiovascular symptoms can also be seen. Some chronic hypocalcemia symptoms are a lot of manifestations with the skin, unfortunately, and this can result in dermatitis, eczema, as you see here on the right in the picture, as well as brittle or grooved nails. You may also see hair loss in these patients that have hypocalcemia. In regards to acute hypocalcemia, asymptomatic hypocalcemia due to hypoalbuminemia requires no therapy. As long as you do that correction formula and you get 8.5 or more, you're pretty much okay. Typically, calcium does not need to be replaced unless you have severe hypocalcemia of less than 7.5. You can actually get away with a level of 8.0 in the body and still be okay. So in regards to replacement of this, IV calcium gluconate or IV calcium chloride may be given for this. And it's important whenever you're giving these calcium salts not to give it in the same line as a phosphate salt, because that may actually precipitate. In regards to calcium gluconate versus calcium chloride, calcium gluconate is preferred. Though calcium chloride will provide about 3 times as much elemental calcium compared to calcium gluconate, and that's why we reserve calcium chloride for emergency or urgent situations. It also has to be administered in regards to calcium chloride with a central line, as tissue necrosis may occur, particularly if administered via a peripheral line. So it's important that you must administer calcium chloride via a central line in a big vein, ideally. You can monitor serum calcium levels daily throughout repletion and routinely every 24 to 48 hours if no repletion is required. As you see here, these are the typical empiric treatments with IV calcium. What I essentially want to draw your attention to here is that for asymptomatic hypocalcemia, you use the gluconate salt. If you have severe or symptomatic hypocalcemia, you can use either chloride or gluconate salt. But remember, with chloride, you have to have a central line, and it provides about 3 times as much dosage compared to the gluconate salt. So that's the important points I want you to get from this part. In regards to patients who have a chronic calcium deficiency problem, there are many different calcium supplements that are out there. The thing that I want to draw your attention to here is if you're going to give PO calcium, is that your calcium gluconate and your calcium chloride have a 3-fold difference in elemental calcium. In regards to oral administration specifically, all of the calcium salts come in oral form except for calcium chloride. So some of the common ones that are used in practice are calcium citrate, calcium carbonate, as well as calcium acetate. The next thing we'll talk about is hypercalcemia. Or I'm sorry, the next diagnosis we'll talk about, not thing. Hypercalcemia is defined as a calcium concentration greater than 10.5, with moderate hypercalcemia levels being 10.6 to 12.9, and severe being above 13 or equal to 13. In regards to hypercalcemia causes, the two primary causes of hypercalcemia are malignancy and cancer and hyperparathyroidism. Regarding malignancy and cancer, this is commonly a presentation seen with what is called tumor lysis syndrome, or essentially hypercalcemia of malignancy. So that's important to be aware about, because this may actually require pretty hefty treatment. Hyperparathyroidism is another common cause of hypercalcemia. You may also see it with some medications such as hydrochlorothiazide or lithium. You may see it with vitamin A or D toxicities, something called milk alkali syndrome, adrenal insufficiency, immobilization, where essentially at that point your osteoclasts are basically breaking down a lot of bone and releasing it out into the serum, Paget's disease, rhabdomyolysis, and tuberculosis. In regards to hypercalcemia signs and symptoms, mild hypercalcemia is usually asymptomatic. It's where you get to the severe hypercalcemia where you start seeing the symptoms, such as anorexia, fatigue, confusion, bradycardia, again the ECG, EKG changes, coma, and death. One thing I do want to note with chronic hypercalcemia, and this can be not necessarily severe, but at any level, you may actually see the development of kidney stones, or nephrolithiasis, metastatic calcifications, and renal failure. The calcium can essentially do a lot of damage to the kidney through its mechanism producing calcifications. In regards to acute hypercalcemia treatment, mild hypercalcemia is generally responsible to hydration. So if you have a patient with mild or severe hypercalcemia, you can actually give them IV hydration with normal saline to reverse intravascular volume contraction that was actually caused by the hypercalcemia itself. After hydration, you can give a loop diuretic such as furosemide to increase calcium elimination. And in cases where you have lethal situations, hemodialysis may be preferred. In regards to chronic hypercalcemia treatment, bisphosphonates such as pamidronate or zoledronic acid may be given. These two bisphosphonates specifically have FDA indications for hypercalcemia, particularly related to the malignancy itself, versus the other ones which do not. It's important not to give phosphate salts with these, as it may cause calcium phosphate precipitation, which again will hit up a lot whenever we talk about nutrition support. The last electrolyte we will talk about is phosphorus. Phosphorus is the main intracellular anion in the body. So remember, phosphorus or phosphate is negatively charged. Regarding phosphorus, our normal serum concentration of phosphorus is between 2.5 to 4.5. The majority of phosphorus exists in bones and soft tissues, with only 1% of total phosphorus stores in the extracellular fluid. Therefore, like many of the other electrolytes, serum levels may not actually reflect total body levels. So you may have to actually do some extra replacement on these patients if needed. It has roles in bone composition, cell membrane composition, nerve conduction, and muscle function. But most importantly, it's involved in all processes that involve ATP, because if you think about ATP, which is adenosine triphosphate, it is one of the main components of ATP. Therefore, it is involved in any kind of energy process that happens in the body. And remember, ATP is a cofactor for many other different processes in the body. Therefore, phosphorus plays a very important role here. Regarding hypophosphatemia, hypophosphatemia is defined as a serum phosphorus concentration of less than 2.5 milligrams per deciliter. And the severity just really depends on the symptoms. Asymptomatic is considered mild, and symptomatic is considered either moderate or severe. In regards to causes of hypophosphatemia, malnutrition is one of the biggest causes of hypophosphatemia, though it may not necessarily be the biggest cause, particularly with refeeding syndrome, which we'll discuss more with nutrition support. So essentially, if you're not getting, overall in the beginning, if you're not getting the nutrition in, you may not be getting enough phos in, but you may also have this other syndrome called refeeding syndrome that can occur as a result of nutrition support, and we'll talk about that later whenever we talk about nutrition support. Hypophosphatemia can also result in alkalosis, or essentially a high level of pH, in metabolic or respiratory disorders. It can result in DKA, which we talked about earlier in the semester. Alcoholism is another big cause of hypophosphatemia, as well as a lot of the other electrolyte disorders, such as hypokalemia and hypomagnesemia. Vomiting or gastric ulcers can also result in hypophosphatemia, as well as other therapies. One of the big things that can take phosphorus out of the body is dialysis. So if you have a patient hooked up to a dialysis machine, remember those phosphorus molecules are very, very small. Or those phosphorus atoms, I apologize, phosphorus atoms, phosphorus ions. Insulin can shift phos into the cell, therefore that's a reason that can result in hypophosphatemia in the serum. Diuretics can cause elimination, and acids can actually bind to phos, such as calcium-containing acids. Sucralfate, which is essentially an increaser of gastric pH, can cause hypophosphatemia from binding it up in the stomach, as well as carbohydrate loads, which kind of goes back to this refeeding syndrome phenomenon that we'll talk about whenever we talk about nutrition support. Some signs and symptoms of hypophosphatemia include impaired diaphragmatic activity, so problems actually breathing in and out, and that can lead to acute respiratory failure. So it's important in the patients who have acute respiratory failure and who require essentially a mechanical ventilator, as you see here with this nice little lung patient, a machine that helps them breathe. So in patients who are on mechanical ventilators who have acute respiratory failure, we want to aim for relatively moderate levels of phos, above 3 ideally. Tissue hypoxia can be a sign or symptom. Decreased myocardial contractility because of lack of ATP. Paralysis, weakness, paresthesias, essentially movement disorders. Neurological dysfunction, seizures, and then even death can occur from lack of phosphate and phosphorus. In terms of treatment of hypophosphatemia, if the hypophosphatemia is asymptomatic or if it's chronic, you may treat with oral phosphate supplements if the GI tract is functional. However, a problem with these oral phosphate supplements is that many of them cause diarrhea, and many of them have unreliable absorption. A lot of these products are also available as powders and have to be dosed multiple times a day, which also makes them inconvenient. If you have moderate or severe hypophosphatemia, you want to do IV phosphate supplementation with these patients. Sodium phosphate is preferred as the IV regimen of choice. However, you can use potassium phosphate if the patient also has hypokalemia at the same time as hypophosphatemia. That would be the best answer in that case. Just something that is important to know regarding phosphate and phosphorus. Because the units of phosphate products are in millimoles, it's important to remember that these also convert to standard milliequivalents. So, for example, if you have 1 millimole of sodium phosphate, that's equal to 1.33 milliequivalents of sodium. If you have 1 millimole of potassium phosphate, that's equal to 1.47 milliequivalents of potassium. Like many of the other electrolytes, if you have renal dysfunction, reduce your dose by 50% before you actually give it to the patient, because this can result in overaccumulation. It's important to monitor serum phosphorus levels about 2 to 4 hours after they get their replacement dose, and then routinely every 24 to 48 hours. And note that the maximum IV phosphate infusion rate is between 7 and 7.5 millimoles per hour. This is done to minimize any vein irritation that may occur with the phosphate infusion. So therefore, if you're giving 30 millimoles of a phosphate product, it may take you 4 or more hours to actually infuse it. And some hospitals actually have their infusion rate at lower marks. But per the available data that's out there, 7 to 7.5 millimoles per hour is safe and does not cause any significant or clinically significant adverse effects. In regards to hypophosphatemia treatment, I'm not going to necessarily expect you to know the dosing of this treatment here. What I would expect you to know is that they traditionally range anywhere between 10 millimoles and 40 millimoles total, depending on the weight of your patient. So it does depend on this level here. In contrast, let's talk about hyperphosphatemia now. So this essentially just means serum phosphorus concentration of greater than 4.5. The most common cause of hyperphosphatemia is renal insufficiency. So if you're not able to get rid of phos through urinary excretion, then you might have hyperphosphatemia. Or if you have excessive IV or PO phosphate administration already. There are also some laxatives, such as fleet enema, that may contain phosphate, and as a result, they can also be a risk factor for hyperphosphatemia if they're being given chronically. Acidosis, metabolic or respiratory, may cause hyperphosphatemia. Hemolysis or breakdown of red blood cells. Rhabdomyolysis. Because remember, phosphate or phosphorus is intracellular. So if you have destruction of cells, essentially it will leak out into the extracellular space and into the vasculature. Hypoparathyroidism, as well as vitamin D toxicity, are also reasons to have hyperphosphatemia. Signs and symptoms. A lot of the signs and symptoms of hyperphosphatemia actually have to do with hypocalcemia. So patients who have hyperphosphatemia may present with hypocalcemia as well, since there's essentially an inverse relationship between these two electrolytes. And essentially what can happen is that if you have hyperphosphatemia, you may bind up a lot of that calcium. That calcium with the phos will essentially result in precipitation that will lead to crystal production in the body, and that can lead to organ damage. And the risk increases whenever you have a serum calcium and serum phosphorus product of 55 to 60. So essentially what you do is you multiply the level of calcium concentration in the body and the level of phos, and then essentially just multiply them out together. And if you get a number greater than 55 to 60, you have a high risk of that calcium phosphate precipitation occurring. You might also have tetany and other hypocalcemia symptoms as a result of hyperphosphatemia too. Hyperphosphatemia treatment. The treatments of choice are essentially phosphate binders, and there's certain ones that are preferred. Calcium salts are preferred for chronic therapy, such as calcium acetate or phos-low, or calcium carbonate, TUMS. Now, phos-low is a term essentially meaning low phosphorus or low phosphate. However, the brand of phos-low is not marketed anymore, to my knowledge. I believe it has been discontinued. But some people may refer to calcium acetate as phos-low, so just be aware about that. Calcium carbonate comes in more formulations than just TUMS, but TUMS may be sufficient if given in a proper dosage to meet the calcium carbonate dosing requirement, depending on what dosage of TUMS you actually have. Aluminum salts are also used as phosphate binders, but though they're not preferred because they cause constipation, and they also accumulate in renal dysfunction. Magnesium salts can also be used as phosphate binders, though those are not also preferred because they cause diarrhea, and they also accumulate as well. Other than calcium salts, which are preferred, sevelamer or Renagel or Renvela, depending on which salt that you have. Renvela is the sevelamer carbonate form, and Renagel is the hydrochloride form. Can be given. However, sevelamer is pretty expensive. Upon last research, I saw that sevelamer actually cost about $20 per dose average wholesale price, depending on which formulation you actually get of it. So therefore, because it's expensive, you should reserve it for hyperphosphatemia with concurrent hypercalcemia where you can't give a calcium salt, or for refractory hyperphosphatemia that's not responsive to calcium salts. Here is the summary of the hyperphosphatemia treatments. Ideally here, all I need you to know, essentially, from this list is just the medication options. Now, if you have a patient who does not respond to these agents, dialysis can always be a last-line option to get the phos off, though if you can do it with a medication versus doing dialysis, obviously go for the medication route first, because dialysis is a little bit more invasive. Remember, in any electrolyte disorder, always treat the underlying cause first, if possible. If you can't treat the underlying cause, or if you're treating the underlying cause and you still need a drug, that's fine. But the best answer is always to treat the underlying cause of whatever electrolyte disturbance you have first. Here is the reference to the Kraft review article where a majority of this information came from. And we'll go back to the case questions. So we have a patient who's a 35-year-old male presenting to the ED with ultra status, nausea, vomiting, and alcohol withdrawal. He's barely eaten in the last week. His labs include sodium 140, potassium 3.1, chloride 96, bicarb 22, BUN 23, serum creatinine 1, and glucose 87. He has a peripheral IV line. What electrolyte disorder does he have? The answer here is hypokalemia. His K, or potassium, is 3.1 currently. The normal range for potassium is between 3.5 to 5.0. He doesn't have hyponatremia because his sodium is 140, normal range being 135 to 150. Hyperkalemia is out here because he has hypokalemia. Hyperkalemia would be a K above 5.0. And hypermagnesemia, the magnesium is not even measured here, but if he did have hypermagnesemia, his mag would be 2.4 or higher. What concurrent labs should be obtained to potentially determine the cause of GB's electrolyte disorder in question 1? The answer here is serum magnesium, essentially. So kind of going back to the concept of magnesium being a cofactor for that ATPase sodium potassium transporter pump. In addition to the increased renal losses that may occur, magnesium should be obtained to determine the etiology of hypokalemia, unless you already know what the etiology is. And assuming the lab taken in question 2 is normal, how should GB's underlying electrolyte disorder be treated? The answer here is potassium chloride, 10 milliequivalents IV times 4 over 4 hours. So remember, he has a peripheral line, so maximum rate that you can infuse in a peripheral line is 10 milliequivalents per hour. And because his Potassium is 3.1. If we want to get to 3.5, ideally we need 40 milliequivalents total. From the information that we have in the case, he has relatively normal renal function. It would obviously be prudent to obtain a urine output, but his serum creatinine looks great. Therefore, we would want to replace him with 40 milliequivalents of total to theoretically get him up by 0.4 milliequivalents per liter of serum potassium for his level. We wouldn't give him calcium gluconate unless he had like hyperkalemia or had like hypocalcemia or something similar. Normal saline, we wouldn't give him in this case. And insulin and dextrose would be given in hyperkalemia, but remember with hyperkalemia, the insulin has to be IV, not sub-Q. So this answer is just completely wrong here. If you have any questions, please feel free to contact me regarding the miscellaneous electrolyte disorders. Thank you and have a great day.